Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have yet another very interesting case. This patient attended with bilateral fully occluding earwax, and I'm just commencing with their left ear. Now, they didn't have much hearing in this ear, and that was due to a sustained head injury many years ago. I think it was in 1989. And unfortunately, the patient had a brick wall collapse upon them, and subsequently, they suffered from head trauma. And more specifically, they had a cerebrospinal fluid leak. So, the cerebrospinal fluid is some fluid that surrounds your brain and spinal cord, and it acts almost like a buffer. It protects your brain and spinal cord from injury. But this had leaked, and it had leaked out of their ear, and they had many symptoms. One of them being hearing loss. So it's very likely that this head trauma also caused what we call perilymph fistula. Within the organ of hearing, there's two types of inner ear fluid, one called endolymph, the other called perilymph. And if this fluid, especially the perilymph, leaks out of the ear, it can cause death to the little sensory hair cells within the organ of hearing. They did have some residual hearing, but it was they reported it to be almost 90% hearing loss on this side. They also sustained a perforation of the eardrum, which they advised had since healed. But what was really interesting, and you'll see this in a moment once I remove this plug, which I should add was really occluding and impacted. They had a fracture of the temporal bone of so the temporal bone is the bone that encases the ear canal, and very deep in the ear, so medially, and more specifically to the back part of the ear canal and also the roof of the ear canal. There was a fracture there, and this patient wasn't aware, and it hasn't caused them any problems, and I did show it back to them. So I've never seen that before myself. I've never seen a fracture of that nature of the ear canal. Now, the patient has said they weren't aware themselves that they had that, and as you can see, I've put some oil in. We've got to be careful. So if the patient's got a perforation of the eardrum, or if they've got an opening in the ear canal, so for example, if they've got a mastoid cavity where the back part of the ear canal, the bone is drilled away, due to an infection which enlarges the ear canal. You've got to always be careful when using drops, because it can then lead to an ear infection. And so I did put some drops in here to soften this wax, but unbeknown to either of us, they had this fracture. The fracture, the bone has got a layer of skin over it, so the drops didn't penetrate through, fortunately. And you can see I'm just wriggling this away. This plug was really impacted, had skin adhesions around the edge. It was of that soft glutinous consistency, which can be difficult to remove. I think at this stage I was just about to reach out for the Jobson horn, because I brought this wax plug forwards near the entrance, which gives me scope then to insert the Jobson horn and remove it. But I felt I was almost there with the suction probe, so I was just continuing. And you can see it's coming away now. And despite their significant hearing loss, they did feel that the removal of the wax did improve their hearing, so they were really pleased. So there we are. I'm going to freeze that in a moment, and I'm going to insert a line where the fracture is. They have got a retraction of the eardrum, it's sucked in, so that's that fracture line. So it's quite a significant one, and it's of the posterior superior medial canal wall. That's the medical term given to it. So now I'm just going to peel some dead skin. I'm using the fine end suction probe just to avoid clarinetting. And so this skin's on the front part of the ear canal. It was quite a thick layer of skin. I didn't want to use any more drops. Now that I knew that this patient's got that fracture, I wanted to avoid using any drops. So I'm just going to peel away this skin, which is quite dry and adhesive, but we did manage. So I'm just mopping up near the entrance to get a better view. I just wanted to see what was underneath this blanket of dead skin on the back part of the ear canal, because they obviously sustained this head injury, there could be other trauma inflicted within the ear canal, which can, for example, create a little pothole, a little crater, or an erosion within the ear canal, or some dip abnormality. And that then lends itself very well for dead skin that's shedding and migrating out of the ear to fall inside. And when you've got dead skin collecting within an opening or widening or pothole in the ear canal, it can get infected and it can lead to a canal cholesteatoma, or malignant osteitis. And they are quite localized within the ear, canal cholesteatomas. They are very rare, but if you do come across one, they are very localized at specific points within the ear canal. And the canal cholesteatoma can infect the surrounding bone. It can spread upwards towards the brain, towards the jaw, to the skull base. So it's very important that if someone has got a canal cholesteatoma, it's treated with by an ENT surgeon. Typically, you'll get some discharge, some mucopurulent, foul smelling discharge coming from the site where the canal cholesteatoma is developing and expanding and growing. And you typically get erosion of the bone, the bone itself, the temporal bone. So again, I just want to ensure there's nothing sinister hiding underneath this bone, underneath this blanket of skin. And it's happened a few times in the past when I've removed a thick layer of skin like this and it's revealed a more sinister pathology. So nearly there. I'm quite satisfied now that there's nothing hiding away, at least on the inferior portion, so the base of the ear canal. Because I'm not using any drops to soften the skin, it was really tricky actually. There's still a bit left on the back canal wall. So I'm just having another look at this fracture line. I was fascinated by it, as you can probably tell, because I've had quite a few close examinations. And then I'm just going to go back in and see if I can peel away a bit more skin. Do stay tuned for their right ear. In fact, it was their right ear that was more blocked with earwax. And of course, the right ear was this patient's better hearing ear, so that was more important. When the patient arrived, I actually did perform the procedure in their right ear first, but I wanted to show you their left ear first because of the fracture of the bone in the ear canal. So you got a really crystal clear view and image. You can see all the blood capillaries there. In terms of treatment for that bone, I have referred the patient to ENT via their GP just in case. We're making the assumption that this bone was fractured at the time of sustaining the head injury, but we can never be sure, and the patient themselves wasn't aware. So for that reason, I have referred the patient back to their GP. The GP may have a record of this through past examination or referral letters. If not, the GP may decide to refer the patient onwards to see an ENT specialist just in case there's nothing else causing this. And I've bent the tip of the fine end so I can get better access and range to the back part of the ear canal. You can see the skin peeling away. And it's really adhesive, really thickened skin. It's actually on the eardrum. You can see it's going to come away. I've got to be careful with that fine end that I don't make contact with the front part of the ear canal. So as I'm manipulating the fine end suction probe, I'm moving it left and right, wriggling it around. You've got to just make sure that you don't inadvertently make contact with the sides of the bony part of the ear canal. There we are. So last few. So you can see they have got a retraction of the eardrum. That retraction is caused by negative middle ear pressure. Negative middle ear pressure essentially means there's less air behind your eardrum in comparison to the atmosphere and within your ear canal itself. And ideally, we want the air pressure either side of the eardrum to be equal. When the air pressure is equal either side of the eardrum, that's when your eardrum is most mobile and most compliant, and it vibrates the most in response to sounds. So that provides you with optimal hearing when the air pressure is equal either side of the eardrum. For air to enter the middle ear space, it has to travel up the nose and then up a tube called the eustachian tube. The eustachian tube is a connecting tube between the back of the nose, the nasopharynx, and the middle ear, so the cavity behind the eardrum. The eustachian tube is typically shut during normal resting state, and it's during brief moments of chewing, yawning, swallowing that the eustachian tube, the muscles either side where it connects to the back of the nose, they contract, causing the eustachian tube to momentarily open. And during those brief moments of the eustachian tube opening, air pressure can equalize itself. So if there's not enough air behind the eardrum, air can enter, or if there's excessive air in the middle ear, air can escape. The eustachian tube also serves as a drain pipe, so any fluid that accumulates behind your eardrum can drain away. If that eustachian tube, however, gets blocked or is obstructed, or the muscles are weakened or paralysed and no longer contract, if that eustachian tube for whatever reason is not able to fully open, that prevents the ear from equalising itself in terms of the air pressure, which means there's a lack of air behind the eardrum. Any air that remained in the middle ear soon enough gets absorbed by the cells within the middle ear, which means there's a negative middle ear pressure. And when you've got negative middle ear pressure, it creates a suction, a vacuum effect. Your eardrum gets pulled in. Very similar to when you're on a plane, or if you're coming down a hill, or indeed if you've got a bit of a cold and you've got nasal congestion. It's the same sensation. And I suffer from it now and again. I had it quite bad last January. I did upload some videos and images of my ear back then, and I actually developed glue ear. So not only was there no air behind the eardrum because my eustachian tube was blocked, fluid wasn't unable to drain, and that fluid built up behind my eardrum in the middle ear and became infected. Instead of having air behind my eardrum, I had fluid, and it was really painful, but it did resolve. After a week, I used nasal decongestants over the counter, which really helped to reduce any inflammation and congestion at the back of my nose. And soon enough, I was back on my feet. Similarly to in their right ear, they also have got a very mild atrial retraction. So I did do a pressure test called tympanometry. Tympanometry assesses the mobility of your eardrum and the three bones, and it also measures the air pressure behind your eardrum to see whether there's any deficiencies, blockages with the eustachian tube. So on both sides, they have got a blocked eustachian tube, thus leading to negative middle ear pressure. So I've recommended also to the patient some nasal decongestants over the counter, and the Otovent nasal balloon is a special balloon. I'm not sure if it's available in the States, but it is in the UK, that you inflate using your nose, and it helps to equalise the air pressure behind your eardrums. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon.